All right. Good morning again, everyone. Let's go ahead and get started for today's session. So last session that I did in March, if you remember, I dealt with some papillary urothelial lesions, mostly neoplasms. So in this session, I will continue on with the flat urothelial lesions. So the flat lesions are very important in terms of urothelial carcinoma diagnosis. So all of you must have heard of the term carcinoma in situ. So whenever we say carcinoma in situ in the bladder, there are two things that we always refer to. Number one is carcinoma in situ is always a flat lesion. When we use this term, it's always going to be a flat lesion. So for papillary urothelial lesions, there's a different terminology. We always add the word papillary to the lesion, whether it's a low grade or a high grade. So this is important because the biology of flat lesions, as I will explain a moment later, and the clinical management, the risk stratification is going to be different. Okay, and then the second thing that we should understand is, so for flat lesions of the bladder, i.e. the carcinoma in situ, it's always high grade. It's always high grade. Whenever we use the term carcinoma in situ, it means you're dealing with a high grade in situ process, which is flat and not papillary. Okay, so these concepts are very important to understand. So you might think, okay, so I have a non-invasive papillary urothelial carcinoma, high-grade non-invasive papillary urothelial carcinoma, for example. So since it's a non-invasive, why shouldn't I be using the term carcinoma in situ here? So we do not use this term. So whenever it's papillary, we always have to use the word papillary. So that's because the flat lesions are usually characterized by mutations that change their biological behavior. They're usually more aggressive lesion. They usually tend to be more multifocal. And the other point is that they are categorized as a high-risk lesion under the clinical risk stratification category for urothelial carcinoma. Okay, so high-risk lesions are managed differently than low-risk or intermediate lesions. So we have to be very careful with the terminology that we are using when we say something is carcinoma in situ in the bladder. So to reiterate, we do not use the term carcinoma in situ in the bladder for any kind of papillary lesion, and we do not use the term carcinoma in situ for any kind of low-grade lesion. It always has to be a high-grade flat lesion. Okay, so these concepts are very important to understand. And as I mentioned, it's because of the biology of the tumor and also because of the way these are risk stratified. Okay, couple of other terminologies that we use while staging these flat lesions are TIS and TA. So flat lesions are always staged as PTIS. So T for tumor and IS for in situ, right? And then, so how do we stage the tumors that are non-invasive, are not flat, and are papillary? So these are staged as you know, PTA. So PTA is an important word here, and the papillary lesions are never staged as PTIS, because to the urologist and the urologic oncologist, when you call something as TIS, it basically means you're dealing with a flat lesion or a carcinoma in situ. Okay, so these concepts, we need to have them clear. All right. So let's go on to case one then. So we just have erythematous lesion over here. There is no detailed history because in most patients, the history is not unique. It's going to be the same type of presentation. They either present with hematuria and come in for a cystoscopy, and the urologist goes in and sees an erythematous or a red patch in the bladder, or they come in for a a different reason, like maybe pain or bladder stone or urinary frequency, and then incidentally, a red lesion or a suspicious lesion is noted by the urologist and it's biopsied. So there is no particular history here for most of the patients who present with carcinoma in situ. In other patients, you might, the urologist might describe a larger tumor that they can visualize, and then biopsies around the bladder adjacent the tumor may show carcinoma in situ type lesions. So that is the other situation in which you might get like a different clinical history. Okay, so this particular lesion, as you can see, it does have normal looking urothelium in these areas. And normal, it is normal looking because the nuclei are nicely polarized. It is low grade in appearance. There are nice umbrella cells on top. The cells are not too large. I don't see any visible nucleolus, right? So as we keep scrolling along, we see that there is a drastic change in the morphology in this particular region over here. And it's very nice to compare the normal urothelium with the change that we see over here. So what is the change that we are seeing? One is immediately obvious that the nuclei are larger here and the nuclei are irregular and they have this abnormal large nucleoli, right? And then the other thing that we see is the fact that there is nuclear overlap. Okay, so there is clear-cut cytologic atypia, and we also see a clear-cut loss of polarization or architectural abnormality, which is different from the normal urothelium here. Okay, and then the final feature that is often helpful in these lesions is the fact that the umbrella cell layer is gone. So here you can see a nice flat umbrella cell layer. But in contrast, in these areas, the umbrella cell layer is completely gone, right? So these features are very helpful in making the diagnosis of carcinoma in situ. It's always useful when you have a comparison of the normal urothelium, as I said, but in some cases, you may not have the normal urothelium, so you will have to depend upon the other morphologic features that I just described, right? So we keep scrolling along and everywhere it's a flat lesion, so it's easy to call this carcinoma in situ. But oftentimes, as you well know, we come across cases in which it's not completely flat. It is slightly thickened, and you might see, like, for example, an area over here, it is slightly thickened, and one could potentially visualize some early papillary formations in this area, right? So there's always a question of, do I call this non-invasive papillary high-grade urothelial carcinoma, or is it actually flat urothelial carcinoma? So it's hard to know when the papillary high-grade non-invasive is in the early stage. It's hard to know whether it's flat disease or papillary disease, right? So is this important? And if this is important, why is this important? So that's the question that we have to answer, right? So again, we have to come to the point of risk stratification. What does it mean to the urologist, right? So the only thing that we have to remember here is the fact that if you have a non-invasive high-grade papillary urothelial carcinoma, that is less than or equal to 3 centimeters. When the urologist says there is a small papillary tumor, and you find that this tumor is less than or equal to 3 centimeters, according to the description, then that tumor will fall under the intermediate risk category, intermediate clinical risk category. All other high-grade lesions will fall under high-risk category. So what are all these other criteria that make the lesion fall in the high-risk category? So number one, any flat carcinoma in situ. Any carcinoma in situ, which is by definition flat, will be high risk. Okay, so what about high-risk papillary tumors then? So any papillary high-grade tumor that is greater than 3 centimeters, or if it's multifocal, will fall into the high-risk category, or any lesion that is recurrent, or if it is BCG refractory, they will all fall under high-risk category. So that, what does it mean to us in terms of trying to call a lesion as non-invasive papillary versus a flat lesion? So let's say you get a first-time biopsy in a patient, and then you see something like this, where you're thinking of calling it papillary versus flat. That is a subjective decision that is very difficult to define, right? So you have to look around, you have to see whether there are clear-cut flat areas like this, then you can call it. But if you have only this, you could put in a comment saying it's not clear whether this is papillary or flat. But in all other situations, let's say the urologist says, the lesion is recurrent, okay, then you don't need to really worry about whether you're calling it flat or papillary, because anyway, it's going to be classified as a high-grade lesion. Or let's say when the urologist biopsies two areas in the bladder for the first time, and both these areas show high-grade tumor, and it's equivocal like this, then also you need not worry, because anyway, multifocal lesions will be categorized as high-grade or high-risk category. So you can just call it whatever you want, and the urologist is still going to treat the patient as if they have a high-risk tumor. So it's important to remember the clinical connotations of what is going on here before we try and use our time in deciding whether a high-grade non-invasive lesion is flat or papillary. So the clinical correlation really matters in this type of situation, okay? All right, so that's a very classic case of carcinoma in situ that is high-grade. So let's go on to case 2 here. So what are the varying morphologic features that we can see in carcinoma in situ? So we'll deal with that aspect in the next 4 or 5 cases. Okay, so in contrast to the first case that we saw, this case is somewhat different. So let me pull up the first case side by side so you can view them together. So this is the first one, clear-cut carcinoma in situ. I'll also show you some normal urothelium in comparison over here. Okay. In contrast, if you look at this case, so it looks slightly pink. I'm not really seeing clear-cut normal urothelium here, but the cells in here are different from what we see in here. I'll put it at the same magnification, I said 10x. So you can clearly see the nuclei are smaller, right, compared to this. And there is not as much nuclear atypia. There is not as much nuclear overlap. And there also seems to be maybe a little bit of umbrella cells on top. So clearly this lesion is not as straightforward as what we see here. But still, we know that this is not normal urothelium. Now, the question is, do we have enough to categorize it as a carcinoma in situ? And if we do, what are the features that we are looking for here? Okay, all right, so let's go back to the basics. So number one, do we see architectural abnormality? Meaning, do we see a loss of polarity? So if I look at this area over here, so I see most of the nuclei are arranged in different angles, right? So, and they're pointing in different directions. So I would say there is architectural atypia here, or architectural abnormality, and that feature is more enhanced in this particular area over here. Okay, and then the next feature that we look for is cytologic atypia. So do we see cytologic atypia? So what do we mean by cytologic atypia? So do we see nuclear hyperchromasia? So we do see nuclear hyperchromasia in many of the cells, and we also see nuclear enlargement. We see some small nucleoli over here. And in addition, as we go around, we also notice some mitotic figures in the urothelium. So all these are features of cytologic atypia. And in addition, we also see areas like this where the umbrella cells are clearly lost. So all these seem to be pointing in the direction of a dysplastic process, and in this case, a carcinoma in situ process. So the other major difference between the CIS over here and what we see here, which you may have noticed even in low power, is that the lesion itself looks pink. Why does it look pink? Because it has a lot of cytoplasm, and the cytoplasm has a distinct eosinophilic appearance. So this is the main point that I wanted to emphasize in this particular case, is the fact that the bright pink appearance in a lesion that looks atypical or dysplastic in a flat lesion should make you think of carcinoma in situ. Many carcinoma in situ acquire this bright pink characteristic in their cytoplasm. And oftentimes when this happens, you can also see if the cell borders are well defined, you can also see the nucleus pushed to the periphery of the cell, somewhat an eccentrically placed nucleus in a cell that is brightly eosinophilic should make you think of the possibility of carcinoma in situ. Okay, this might seem paradoxical to some because when we have so much cytoplasm, the nuclear cytoplasmic ratio that we use so much for cytologic diagnosis of urothelial carcinoma may be very low, right? Not high as we see in this case, but this is also a type of carcinoma in situ in the bladder. And again, I reiterate, whenever you see this bright pink, you should start thinking of carcinoma in situ, and then you start looking for other features that we just saw, the loss of polarity, the atypia, the mitotic figure, and then the loss of umbrella cells. Okay, so that's the concept over here. With that, let's go to case 3. And this is the patient who has a surveillance biopsy. Surveillance biopsy means that they already had some form of diagnosis of urothelial cancer, and they are rebiopsying the patient to see if the cancer has recurred, right? So in this biopsy, we see that from a low power, there does not seem to be too much thickening of the urothelium, and there doesn't seem to be very large cells over here, okay? So let's go closer and see what's going on. So in these areas, we see the nuclei are somewhat smaller. You could say that there is architectural atypia or disarray over here. So as we scroll to the other side, we can clearly identify an area where the urothelium that most of us would classify as normal looking, right? So normal thickness, and we see an umbrella cell layer over here. And we also see nicely oriented or polarized nuclei that are elongated, right? So you can see that they are elongated in a direction that is perpendicular to the basement membrane. So that's another feature that is very helpful in this lesion. But once you go across to the actual lesion, you can see a clear transition here in this area. Where you can see the nuclei are getting more rounded. Even though the nuclear size may not be that large, you can see the nuclear shape is changing. And as you keep scrolling, you will see that there is overlapping of the nuclei. Again, as I mentioned earlier, you have this loss of polarity and you have an abnormal nuclear membrane. It is irregular and not completely rounded. Although I don't see clear-cut nucleoli, I do see a loss of umbrella cell layer. So the whole thing is very suspicious for carcinoma in situ. The only thing that might hold somebody back in this type of situation, especially when you don't see adjacent normal urothelium to compare with, is the fact that these cells look pretty small. So again, let me pull up the first case for comparison. So you can see, put it at 10x, so you can see it better. All right, so look at the size of these cells over here, and I'll make this also as 10x, same magnification, and look at the size of the nuclei over here. So clearly there is a lot of difference between these two. Most of us will have no problems in diagnosing this as carcinoma in situ, but when we see a lesion like this, we might hesitate, right? Because the cells are much smaller. So this is a variant called small cell variant of urothelial carcinoma in situ. Please note that this is not to be confused with the small cell neuroendocrine carcinoma. It is just a morphologic descriptor, which means that the cells are smaller in size, right? Okay, so how do we identify carcinoma in situ when we come across such a situation, right? So the first thing is, as I mentioned earlier, if you have normal urothelium to compare, then things become much easier. And then we look for other features that I mentioned earlier in the previous cases, the architectural disarray and the cytologic atypia. And you also see that there is a loss of umbrella cell layer over here, and you see a higher degree of hyperchromasia. Okay, and in particular to cases in which you have smaller cells or smaller nuclei, another very useful clue is to compare the size of these nuclei with the lymphocytes or endothelial cells that are almost always in the background of these lesions. So for example, if you take a lymphocyte in this particular case, so there's a lymphocyte, and compare it with the nucleus of the tumor cells. So the largest nucleus of the tumor cell. So you will find that the nucleus of the tumor cell is at least 3 times the size of the lymphocyte nuclei. So you can put like more than 3 lymphocyte nuclei over here. So in many places, you can see that type of change. So there's a lymphocyte over here. So you can easily fit 3 lymphocytes in here. So that size comparison is often helpful when you're trying to determine if a atypical lesion that has small cells is carcinoma in situ versus just some type of a reactive change. So again, you see a nucleus over here, and you can pick any lymphocyte here, maybe this one or maybe that one. So you can easily fit more than 3 lymphocytes in here. So in most reactive lesions, the nuclei may be somewhat enlarged, but it's typically lesser than 3 times the size of the lymphocyte nuclei or the endothelial nucleus that is cut in a transverse section. Okay, so this is a small cell variant or small cell type of carcinoma in situ. Again, remember that it has nothing to do with small cell neuroendocrine carcinoma. It's just the size of the cells that is small. And prognostically, it does not have any particular difference in tumor behavior compared to the usual type of urothelial carcinoma in situ. It is merely a morphologic descriptor for pathologists to identify. Okay. So that's case number 3. So let's go on to case number 4. Again, we have another surveillance biopsy. So in this case, let's zoom in a little bit. You will see that there is some inflammation in the stroma, and in many places, the urothelium seems okay. So we have quite a thick layer of umbrella cells over here, and the urothelium here looks normal. But as we scroll to the right over here, we can see that the umbrella cells seem to be lost, and there may be some concern, especially if you're going down into 40x. So that's another critical feature in urothelial carcinoma in situ diagnosis. If you go into really high power, so I cannot go more than 20x here because they are scanned at that magnification, but in a microscope, if you go to 40x, you can see very well why some of these lesions could be mistaken for that small cell type of carcinoma in situ, because you do start seeing some hyperchromasia over here, and you could envision that many of these are not polarized very well, and you see sometimes the denudation of the umbrella cells, which could make you think that might be carcinoma in situ. So be very careful about that, and try not to go into 40x before you're able to make the diagnosis of carcinoma in situ. So the other clue that I mentioned in the previous case, the size of the nucleus in comparison with the lymphocyte. So here you can see some lymphocytes here, here, and here. And if you compare that with the size of the nuclei over here, you will see that none of these nuclei are greater than 3 times the size of these lymphocytes or endothelial cells in the stroma underneath. So that is often a very useful clue for you to determine if a slightly atypical area like this, where there is denudation of the umbrella cells, is carcinoma in situ or not. Okay, so always keep that in mind. So why are we looking at this case then? So let's scroll around a little bit. We already know that this patient has a surveillance biopsy, which means they had a prior diagnosis of urothelial carcinoma. So in such cases, one has to be very, very careful to examine all regions of the biopsy carefully. Okay, so we go into another region over here where we again see there is some denudation. So if you go closer, can see some really dark nuclei, ink dot-like nuclei that seem to be very large and that seem to be having a high NC ratio. So in this particular nucleus and maybe this nucleus, for example, if you compare the size of the lymphocyte, like maybe here, you will see that they are larger than 3 times. So areas like this really raise concern for carcinoma in situ. Okay, let's scroll around a little bit more, and then we see another area where there is a denudation, right? So over here, we see the umbrella cells are gone, and then we can see that there are some very dark appearing nuclei over here, and they have a high NC ratio. And again, there is some suspicion. You don't want to go into very high power, but when from a 20x, if you look at this and try to compare the size of this nuclei with the size of the lymphocytes, let's take a nice round one over here. This is a nice lymphocyte. You can easily fit more than 3 lymphocytes in any of these nuclei. So this is actually small focus of carcinoma in situ in this particular patient. And this is a type of carcinoma in situ which denudes very easily, because the cell-to-cell adhesion in carcinoma in situ is often lost. And some people term this as a denuding cystitis. So denuding cystitis is just another term that is used by clinicians and pathologists for carcinoma in situ that sheds up the surface, okay? And it's important to understand this because it's often difficult to identify, because you may not see the type of cells that you see in a typical case of carcinoma in situ. There may be just a few dark hyperchromatic nuclei with high NC ratio that's sticking onto the surface, okay? But it's important to make this diagnosis. So this is a denuding cystitis variant of carcinoma in situ. All right, so that is case number 4. So let's go on to case number 5. But before I go on to case number 5, I just wanted to show one small feature that we have to be aware of when we are thinking of carcinoma in situ in these type of lesions where you have only very few cells. So we find some of this feature in this particular field itself. So the aspect that I wanted to focus on here is that umbrella cells can often show degenerative type of atypia. They can often show binucleation. They can often show some type of hyperchromasia that can mimic carcinoma in situ. And that should not be mistaken as carcinoma in situ, right? So let me show you an example from my microscope over here. So all of you can see the screen, and you can see in the center over here, there are these somewhat larger cells with irregular hyperchromatic looking nucleus and with a pink cytoplasm that look very atypical and suspicious, more so because they are not located at the top and they are located somewhat in the bottom or the center of this cell layer or this urothelial layer. So that happens because the sometimes due to tangential sectioning, it appears as if the umbrella cells are in the center of the cell layer rather than at the top. So one has to be aware of that feature. So how do I tell confidently that this is an umbrella cell and not an atypical cell that is representative of carcinoma in situ? So there are a few clues. One is you have to first identify that it might be a tangential section here. The other is the umbrella cells often have some squamoid features. So you can see, sometimes you can see the cell borders of these cells. So you can see a nice polygonal shape that you often see in squamous epithelium. Okay, that's one. And then the other feature is that the nuclei are often, they have the smudged chromatin. So you can see the smudgy, vague appearing nature of this chromatin over here compared to carcinoma in situ, where you find more often this vesicular or granular chromatin, right? And then the other feature is you don't really see nucleoli that are prominent in the degenerating umbrella cell. Okay, unlike carcinoma in situ in most cases. And then if you go real close, you can see that these are not actually single nuclei, but multiple nuclei. So here you can see at least 2 nuclei, and here you can see multiple nuclei that are clumped up together, right? So that indicates that this is not a true carcinoma in situ, and in fact, this is actually a degenerating umbrella cell that mimics carcinoma in situ. And as in this case, you can sometimes have it represented in the middle of the urothelium due to a sectioning artifact. So one must be aware not to call this as carcinoma in situ. Okay, so let's go back to our case over here and then move on to case 5. Okay, so case 5, again, we see a flat urothelium. Okay, nothing seems to be overtly abnormal from this particular magnification. So let's try to look a little bit closer. We see some von Brunn nest with cystic change. Most of the urothelium appears fairly normal appearing. So this is normal. But here we start seeing some cells that are larger and hyperchromatic. And you see just this, you might think, okay, maybe that's just an umbrella cell with Atypia. But then when you come over here, you clearly see it in deeper layers. And there is irregularity that is very concerning, both in terms of cytologic aspect and in also architectural aspect. So there is a degree of disorder that we see over here, especially when you compare these areas and this area to the normal urothelium over here, you can clearly see that this area is different. So this is actually carcinoma in situ. The changes that we have going on over here from this area to this area is too much for us to consider all of it as just representing umbrella cell atypia. So this is real, and there is no tangential sectioning here. So this does look like high-grade atypia that is very concerning, if not diagnostic, of carcinoma in situ. So the reason I wanted to show this case is the fact that you can see some cases in which there is carcinoma in situ, but fairly intact umbrella cell layer. So you can see here, from over here to all the way here, you can see a fairly intact umbrella cell layer, and underneath that you have carcinoma in situ. So the thing that I want to emphasize here is you may not always see a complete loss of umbrella cell layer in carcinoma in situ. So do not put a lot of weight on that fact or that feature, right? So most of the times I would say you would lose the umbrella cell layer, but that does not happen all the time, as you can see in this case. So be aware of that, okay? So that's case number 5. So case number 6, this is a ureter margin resection for a cystoprostatectomy specimen that was done for urothelial carcinoma. And this will show you another variant of carcinoma in situ, which is called as a Pagetoid spread of carcinoma in situ. This is another situation in which you might see an intact umbrella cell layer. This is another situation that you have to recognize in urothelial carcinoma in situ, especially when you're evaluating margins like this. When it's not very close to the tumor, you might still get tumor spread through this phenomenon called Pagetoid spread of the cancer, right? So what is Pagetoid spread? Pagetoid spread is when carcinoma, urothelial carcinoma in situ, from a particular region spreads to a different region by undermining the epithelium. So what is undermining? We call it undermining when we see the carcinoma, which is spreading along the basal and parabasal layer and lifting up the normal epithelium. So it undermines the normal epithelium on top. So you can clearly see here an example of this Pagetoid spread. So these are very, very atypical cells, very large nuclei, very prominent nucleoli. And you might think, okay, it somewhat resembles the umbrella cell that I was showing earlier, because it does have a very low NC ratio, abundant eosinophilic cytoplasm. But notice the difference in the nuclear chromatin. That's what I was trying to tell you earlier. So the chromatin over here is vesicular chromatin, unlike that smudgy, denatured chromatin that we saw in the umbrella cell. And you do see prominent nucleoli. So this is bona fide carcinoma in situ that is growing in a Pagetoid manner underneath the epithelium over here. And as we look around, we can see more and more areas that clearly show this type of Pagetoid spread. So you can see here, that's normal urothelium, but underneath you have this Pagetoid spread. It's even forming some nests over here. So this type of pattern is very important to recognize because you might see some cases in which these cells are very subtle and kind of hidden. So be aware of the Pagetoid spread, like an area over here, you might only see something like this. Most of the urothelium looks normal otherwise. Okay, so this is an important pattern of carcinoma in situ to recognize. Pagetoid carcinoma in situ. All right, with that, let's move on to case 7. So this is a patient who's coming in for a hematuria workup. And here you see a section of the bladder wall. And even from this magnification, you can see that you can note that there is a denudation of the urothelium on top, but we do see an exuberant proliferation of a Brunn nest, okay? In the last session, we spoke about trying to differentiate between Brunn nest and the nested variant of urothelial carcinoma. One of the features that really helps in making the differentiation is the extent of spread into the wall, right? So Brunn nest always stay confined to the superficial lamina propria. The way we define superficial lamina propria is by identifying the bundles of the muscularis mucosa, okay? So here you see muscularis mucosa, which is disrupted because of the edema, but you can see all these bundles are still, here's the muscularis mucosa, or above the layer of the muscularis mucosa, which means they are in the superficial lamina propria, and they are not nested variant of urothelial carcinoma unless you can see other features that help you identify that. Okay, so that we discussed in the last session, so I don't want to go into too many details right now. So the reason I'm showing this case now is the fact that there is something here that you may want to notice. Okay, so one thing to remember before we go into that is the fact that when you see urothelium in the setting of a von Brunn nest, you will see a little bit more atypia than the cells that you actually see on the surface, than the normal urothelium you'll see on the surface. So as you can see in this typical Brunn nest, which also has a cystic change, you can see that there is some loss of architecture. So all the cells seem to be pointing in different directions. They seem to be piling up on each other. That's just the nature of the Brunn nest. So you have to be prepared to see a slightly higher degree of atypia. However, as we keep scrolling, we see something that is a little bit different. So this particular nest over here looks quite different from the Brunn nest over here, flanking on either side. Why? Because again, we come across this more intense eosinophilic cytoplasm that we saw in case 2, the erythematous lesion, right? And then we also see several nuclei that are hyperchromatic. The size of the nuclei itself doesn't seem to be too different from what we see in the Brunn nest, but the other features make us concerned. There is loss of polarity here, there is hyperchromasia, maybe some nuclear overlapping, and then the intense eosinophilic cytoplasm. And it looks very different from the other Brunn nest. So we are worried and we start looking for more areas. And then here you can see this nest over here, and then the other nest over here. They clearly stand out from the surrounding Brunn nest. Again, the same features, and then you're starting to see more and more atypia. And as you go around, you can see a couple of other nests as well, which show more atypia, and you can also see some mitotic figure, and you can see this apoptotic or karyorectic debris, which means there is higher rate of proliferation in these nests. So this is actually carcinoma in situ that is invading into pre-existing von Brunn nests. So this is a phenomenon that we do see not very uncommonly in carcinoma in situ of the urothelium. And this is a phenomenon that has to be recognized and that has to be reported, right? So why is this so important, and why is this necessary to, why is it necessary to report it apart from just calling it carcinoma in situ? The reason being, in most cases of carcinoma in situ, the urologist is going to treat the patient with intravesical chemotherapy or intravesical BCG, right? And when the urothelium actually, when the cancer enters into the Brunn nest, they are no longer exposed to the surface as you would see the surface urothelial carcinoma in situ, which means the BCG may not be able to reach these areas, which means there is a higher chance of recurrence. So the urologist has to understand this. So to help them understand this, we will let them know that the carcinoma in situ is invading or is infiltrating into the von Brunn's nest, okay? So that's the reason why this phenomenon has to be identified. Okay. And that, let's move to case number 8. So this is a patient with prior history of bladder cancer. And we are having a rebiopsy. So whenever patients have a prior history of bladder cancer, especially when it has been diagnosed recently, this type of changes in the biopsies subsequent to that are very common. So what are the changes we see here? These are essentially changes of injured tissue or a previous surgical procedure being done, right? So you can see here degenerating muscle, you can see some acute inflammation, and you can see tons and tons of blood vessels, some chronic inflammation, very characteristic of granulation tissue formation. You can also see a myofibroblastic proliferation in the background. So what about the surface? The surface in most of the areas is denuded, but we do have some intact surface proliferation here. And you can see that it is indeed proliferating a lot. So there is a thickening of the urothelium. And then when you go closer, you'll notice that these nuclei seem to be somewhat enlarged. And they also seem to have these visible nucleoli, right? And as you keep looking, you may also come across some mitotic figures. So here's possibly a mitotic figure right there. And then you can see another mitotic figure right here. So a combination of these features, including the fact that often you may have surface denudation and what looks like loss of umbrella cells, may make you think of atypia or carcinoma in situ. Right. So what are the features that help us differentiate true atypia or true dysplasia from reactive changes? So number one feature, especially in these sort of situations, is the degree of inflammation. So here, as we saw in the stroma, there is a high degree of both acute and chronic inflammation, which not only is confined to the stroma, but also infiltrates into the overlying urothelium. So you can clearly see the neutrophils infiltrating the urothelium over here. So whenever we have that, this can induce a reactive change in the urothelial cells, which can cause enlargement of the nuclei, which can cause prominence of the nucleoli, which can cause some nuclear overlap, which can increase the mitotic activity, and which can also be responsible for the surface denudation. So in these situations, your threshold for making the diagnosis of carcinoma in situ has to be much higher than a normal. Okay, so the helpful features that will make you call this reactive instead of carcinoma in situ is the fact that despite all these that we saw, you will still have very regular rounded nuclear borders, and you don't really see a lot of nuclear hyperchromasia, right? And then if you compare the size of these nuclei to the size of the lymphocytes, another useful feature that we saw earlier, like for example, there's a lymphocyte over here and there's a nucleus over here. So maybe it's twice the size of the lymphocyte, but not more than 3 times. So in most situations, this is a very helpful feature. So all these put together, plus the fact that there is an abundant amount of inflammation in the urothelium here, should make you diagnose this as a reactive proliferation instead of atypia or carcinoma in situ. Okay, so this is a reactive urothelial proliferation in response to inflammation and possibly prior surgery. Okay, let's move on to the next case now. Somewhat similar theme that we are seeing. So here we see, again, abundant inflammation in the stroma. Most of this is chronic inflammation, as you can see. There is also some acute inflammation, maybe a few eosinophils right there. And then there is some myofibroblastic proliferation, congested blood vessels, and hemorrhage. So clearly this urothelium has been injured, right? So, and then when you look at the surface, you see that it's not very thickened, but the urothelium does seem to be, the cells do seem to be enlarged, right? And you also see some prominent nucleoli in many of these cells. Okay, and there is clearly a loss of polarity. So even though there is not an abundant proliferation here, there is loss of polarity, and there is enlargement of the nuclei. There is enlargement of the nucleoli. Okay, so this makes one think about atypia or carcinoma in situ in this situation. And also compared to the previous case, we do not see that much amount of inflammation, which would make us easily think of a reactive condition. So these cases can get a little bit tricky. So I will show you another field over here. Right here, you can see that there is somewhat more nuclear enlargement and somewhat more atypia that can be really concerning for carcinoma in situ. However, you have other features that sort of detract you from making the diagnosis right away. Like these are features such as you find an intact umbrella cell layer in most places, right? And then you don't really find a high degree of hyperchromasia. You don't really find mitotic activity. And there are areas, despite the fact that there is not a lot of inflammation, there are areas where you can clearly see that the lymphocytes are infiltrating into the urothelium. So these are the factors that are holding you back from calling this as a carcinoma in situ. So this is the situation where I would use the term atypia in the diagnostic line, right? So I do not have enough evidence to call this carcinoma in situ. However, I do not have enough evidence to call this completely reactive either. So this is a situation in which I would use the term atypical urothelium, right? And then leave it at that. In some conditions like this, we just cannot make the difference between carcinoma in situ and reactive atypia. So it's okay to call this just atypical urothelium. Okay, so however, you can qualify this better in some cases. So for example, if we go to case number 8 that we saw previously, we saw atypia in here, but we saw many features in here that that I just spoke about that makes us think this is most likely reactive, right? So in this situation, even if you want to call it atypia, I would recommend we call it atypia favor reactive change or reactive atypia, something like that, to help the urologist understand that this is most likely a benign type of condition, right? So in this situation, it would be difficult for me to say atypia favor reactive versus atypia favor carcinoma in situ. However, let's take a look at case number 10 and see what we're going to do with this one. So again, similar to the previous two cases, we see considerable amount of inflammation in the stroma. We see a lot of inflammation over here, and there seems to be some urothelial proliferation. Even from this magnification, you can say that it's not normal appearing, right? And when you go closer, you notice that there are some mitotic figures in the urothelium, and there's not a lot of inflammation here. There is some nuclear overlapping, there is some nuclear enlargement. So this becomes very concerning for carcinoma in situ. And we go to this fragment over here. Again, we see mitotic activity. We clearly see hyperchromasia, nuclear overlap, nuclear enlargement, and also some small nucleoli. And we also know this patient has a history of bladder cancer. So we begin to worry that this actually represents carcinoma in situ. However, as you look around, and as we saw earlier, we do see considerable amount of inflammation in the stroma, in the urothelium, not only in the stroma, but also infiltrating in the urothelium, which could potentially cause a reactive change. So it's almost like a little neutrophilic abscess. Over here, we see a bunch of neutrophils there. And as we look around, we do see bunches of neutrophils in here as well, which is associated with this atypical looking urothelium. So even though you're extremely worried that this is actually carcinoma in situ because of all the features that we saw, there are these neutrophilic clusters in the urothelium that could potentially represent a reactive change. So in this condition, compared to the previous two, compared to case number 8, where we called it urothelial atypia favor reactive, this is a type of situation where I would say urothelial atypia favor carcinoma in situ, even if I don't want to straight out call it carcinoma in situ. So this is how I use these terminologies. I use atypia favor reactive, atypia favor carcinoma in situ, and in some cases, you just cannot make the difference. You could just leave it as atypia such. But I would warn you to use that term atypia without qualification very sparingly, because if you start using it for a lot of cases, then the urologist is going to lose confidence in your diagnostic ability, right? Okay, now I will address the question that is in the minds of most of you who are listening to this lecture. So how about immunohistochemistry? So will immunohistochemical stains help us in making the distinction between a reactive atypia and atypia that is actually dysplastic? So before we deal with that, I just want to deal with the term dysplasia. So what is this term dysplasia, and when do we use it in the urothelium in the setting of carcinoma, in the setting of flat lesions? So my recommendation is I would never use the term dysplasia at all. Why? Because we just don't have the ability to discriminate confidently between reactive atypia and true neoplastic atypia. So whenever we use the term dysplasia, we are committing a diagnosis towards a neoplastic transformation. Dysplasia, by definition, means there is a mutation, and so there is a neoplastic transformation. So when we use the term atypia, we are actually saying that we are not sure whether this is reactive or whether this is a neoplastic condition. But when you use the term dysplasia, you're committing to a neoplastic condition, and we cannot be sure of that in many settings. So I would recommend not using the term dysplasia at all, right? Okay, so back to immunohistochemistry. So does immunohistochemistry help in making the diagnosis of these lesions? So let me show you an example over here on how immunohistochemistry may or may not help. So this is on the left, you see a clear-cut reactive proliferation. So we see nicely maintained polarity, some enlargement of the nuclei, but not too much. There is not too much of nuclear atypia. There are some small nucleoli, and we see a lot of inflammation in the urothelium. So this is most likely a reactive situation compared to a clear-cut example of carcinoma in situ over here. So what happens when we apply the p53 immunostain? So in most reactive conditions, the p53 should show a wild type pattern where we see some pale staining in some of the cells. So this is a wild type non-mutated p53 pattern, compared to most cases of carcinoma in situ, where we see a dark, intense stain of p53 in almost all of the cells. So this is a mutated pattern, right? So what about other stains? We have CD44. CD44 in reactive conditions should stain full thickness urothelium like this, right? Nice and intense. However, in carcinoma in situ, CD44 either stains only a few cells in the basal layer or does not stain at all. So this is a pattern you would expect in carcinoma in situ. And then finally, we have CK20, which in reactive conditions should stain only the top layer or the umbrella cell layer. However, in carcinoma in situ, it most often stains the entire thickness of the urothelium. So this would be your ideal situation. And when one sees this, one might think, okay, this seems to be very useful. So why do we need to struggle with morphology? Let's just use IHC for all these cases. Unfortunately, the answer is not that easy. So I will show you with a couple more examples. So here's another case of clear-cut carcinoma in situ with some extension into the Brunn's nest over here. And what happens when we apply these stains? CK20, so remember in carcinoma in situ, CK20 is supposed to show full thickness reactivity. However, in a clear-cut case of carcinoma in situ diagnosed morphologically, we see that CK20 is actually negative, right? And CD44 in a case of carcinoma in situ is supposed to be negative, right? Or stain only small area of the basal layer. In this case, you see an intense full thickness staining of the carcinoma in situ like you would expect in a reactive proliferation. It's just because this case is molecularly different. So these stains have to be used very judiciously. They have to be used in combination with your morphological impression and not in isolation at all, because this is an absolutely opposite pattern of what we would expect in a carcinoma in situ. And to top it, we have P53, which actually stains a few cells on almost like a wild type pattern. Right. So this is not what you expect in a carcinoma in situ. This is a pattern that you expect in a reactive condition. So it can be very misleading. And finally, this is another case which is in between the previous two I just showed. So here you can see urothelium that has loss of polarity, that has some overlap, some hyperchromasia, some atypia, but you also have these neutrophilic infiltrates. So this is another situation where you're thinking of, okay, could this be a reactive condition, or is this actually carcinoma in situ? How about immunostains in this situation? So let's look at CK20. We are seeing that CK20 seems to be more or less completely positive in a lot of these cell groups or the layers. And so once when one sees this, you might think, okay, this is carcinoma in situ. But when you do the CD44, you will see it shows almost a similar pattern. Also, almost full thickness staining like you would see in a reactive condition. So how does an immunostain help in this condition to call it CIS versus reactive? You just cannot, right? So immunostains are not the answer for reactive versus carcinoma in situ. In some cases, they might help confirm or refute your morphologic impression, but please remember that your morphology is always number one when it comes to diagnosing these flat lesions. All right, so let's go back to our cases. So we discussed case number 10, and then I have a couple more cases, quick ones before we wind up for today. So case number 11, this is a patient with bladder cancer who had a cystoprostatectomy for invasive bladder cancer. And this is a section from the prostate, which demonstrates a very interesting phenomenon, which we see quite commonly, in fact. So you can see the urethra here, and in the urethra, you can see that there is extreme atypia. So this is diagnostic of carcinoma in situ, which is probably spreading in from the bladder. As we follow this carcinoma in situ, it's on the surface in most of these areas, but you can see it's entering into the underlying prostatic ducts and the prostatic acini as well. So again, as I said, this is a fairly common phenomenon, and the urothelial cancer can crawl through the urethra, enter into the prostatic ducts and into the prostatic acini and expand them, and can go quite deep because all these acini and ducts are actually connected, right? So they can follow that path and go grow quite extensively into the prostate itself. However, the key thing here is to understand that even if it grows extensively like this, it may not be invasive. So the important thing here is to identify whether the urothelial carcinoma is confined to the prostatic ducts and acini, or whether it's infiltrating into the prostatic stroma, because as you know, then the staging will be different. The staging changes, right? So how do we know whether this is invasive or not? So most of these nests are rounded, but some are quite irregular. So it's a difficult situation to know whether this is invasive or not. There are also some areas which do seem to have some type of stromal change or desmoplasia. So let's look at some more areas. So here the nests are quite rounded. So one might think probably not invasive. But what about areas over here? So here it looks very irregular, jagged, and maybe some stromal desmoplastic reaction. So maybe this is an invasiveness. Okay, so I could tell you that a vast majority of these situations where you see urothelial carcinoma infiltrating into the prostatic ducts and acini are not invasive, even though they may mimic invasion because of the irregular, jagged nature of the cell proliferation. And that is because if you look at the prostatic acini, so they do have this irregular, jagged shape, right? So when the urothelial carcinoma enters this, they are going to follow the same contour. So that is the reason for it being jagged, just because they follow the contour of the prostatic acini, not because they are irregular and infiltrative. Right. So how do we actually prove this? How do I know for sure that this is not invasive? And again, that's important because the staging changes. So do immunohistochemical stains help in this situation? It may seem paradoxical, but I would say yes. So I would use the stain CK56 or just CK5, which is a high molecular weight cytokeratin, to highlight the basal cells of the prostate around these nests, which would prove to me that these are not invasive, right? So one might question that logic, because we know that urothelial carcinoma can also be positive for CK56 or high molecular weight keratin. However, CK56 is preferentially more positive in the basal cells of the prostate glands and acini compared to urothelial carcinoma. So let me show you an example of the CK5 stain in this particular case. Sorry. Yes. All right, so here is the CK5 in this particular case that I was showing you. And if you go closer, you will see that the urothelial carcinoma does stain, but you can still identify a clear layer of basal cells in many of these glands. And in areas where the urothelium doesn't stain as well, you're sure that there is a basal cell layer surrounding the urothelial proliferation inside the prostatic duct. So you're not going to call this invasive. So, but what about the areas where we thought it was irregular, jagged? So this is that particular area. And you can see in these areas, it's extremely clear that this is not invasive, despite the fact that it's jagged and infiltrative appearing, despite the fact that it seems to have some sort of a stromal reaction around it. So be very careful in making the diagnosis of invasive urothelial carcinoma when the urothelial carcinoma is involving the prostate gland. So some of these immunostains are actually helpful in making the diagnosis of non-invasive urothelial carcinoma involving the prostatic glands and acini, which makes it still carcinoma in situ or CIS and not T2 or invasive urothelial carcinoma in the prostate. Okay, so that's the teaching point here that I wanted to show. And let's go back to the last case of the day here, case 2. This is a ureter margin in a patient with renal transplant. All right, so we look at this one, it's all flat. And even from this magnification, we can see that maybe there are some cells in here that look slightly hyperchromatic. They don't seem to be too enlarged. There's again a cell over here which is larger, and then these two cells over here which look somewhat different and somewhat unusual. So what's unusual about these two nuclei? The fact is that they seem to have some sort of a nuclear clearing in the center, and the chromatin seems to be pushed towards the periphery, forming a little rim. So there is homogenization of the chromatin in the center of the nucleus with the peripheral displacement of the chromatin other places. And then some areas you do have some hyperchromasia. So this is a phenomenon that might sometimes mimic carcinoma in situ, and it might do that even on cytologic specimens. But most of you know what this is, right? So this is a BK virus cytopathy or polyoma virus cytologic changes in the urothelium. And of course, this is a transplant patient, so they are immunocompromised, so they have a higher incidence of BK virus infection. And This is a classic cytopathic features of viral infection where you see central nuclear homogenization with peripheral displacement of chromatin, which might sometimes mimic carcinoma in situ or atypia for the unwary, especially when you see such hyperchromatic nucleus. You have to keep looking around till you come across some cells that show more clear example of cytopathic viral chain, the central clearing and the peripheral marginization of chromatin. So this is a BK virus or polyoma infection. Okay. So with that, I think we can stop for today. Thank you very much for listening in. And if you have any questions at all, please feel free to ask.
All right, this has been great. Great cases and great examples. There were a couple of questions that got entered in early on. Arun asks why there's localized thickening of umbrella cells in some of these cases. I don't know if they've been related to one of the first cases.
Yeah, I mean, it's just a reactive phenomenon. It's nothing more than that. And it may also be an example of tangential thickening to the top through the top of the umbrella cells, which makes it appear as if the umbrella cell layer is thickened. But essentially, it's a non-specific phenomenon. Yeah, the important thing is to recognize that these are actually umbrella cells and not carcinoma in situ, based on the features that we spoke about.
So in the non-follow-up cases, do these have any sort of particular predilection to symptomatic presentation, hematuria or dysuria or anything like that?
You might find those symptoms, especially if there's a larger tumor associated with it. Oftentimes, when we see carcinoma in situ, it is not an isolated phenomenon. It is a phenomenon that is associated with larger tumors, right? So when there is an actual tumor, then you might see a patient with a higher incidence of presentation with hematuria during voiding. But when there is just focal areas of carcinoma in situ, it might just be an incidental finding. Like, for example, a urologist goes in for, let's say, a bladder stone, and then they find some erythematous areas that are away from the stone, so they get suspicious and they biopsy those areas. So it might be an incidental finding as well in these isolated cases. And more often, of course, we see this in patients who are heavy smokers and who have a long time smoking history. So that's another thing to be aware of, smoking history.
Yeah, very good. So one other question about p53 staining. So in some of the other organs where I spend more of my time, we recognize several different patterns of mutational related staining, and particularly the null type, which may have been one of the stains that you showed there with the negative staining.
Yeah.
I often have been inclined to use P16 as a sort of a marker for that circumstance where you have a null mutation and may find the staining very weak and so forth. Have you ever tried that or used that in the bladder?
Not in that context of P53 mutation, but you bring up a really good point, and I'm glad you caught on to that. The second example that I showed you of in that PowerPoint was actually a null pattern of P53. So it's important to, it's uncommon. You see it, as you know, you see it in female genital tract, uterine malignancies as well, the null pattern of P53 in serous carcinomas and ovarian carcinomas. So the same thing can happen in bladder carcinomas too. When there is P53 mutation, you can occasionally see a null pattern, which is what that case was. But you should not recognize, the important thing is to understand that this is also possible as a form of P53 mutation. You may not always see an intense staining of P53 in that situation. So that's a really good pickup. Thank you for highlighting that. And as far as P16 is concerned, I really haven't used it in the setting of diagnosing carcinoma in situ in the bladder.
Yeah, I think because the P16 is often expressed coincidental with the P53 mutation, in that particular setting where you're wondering, is this null, is this wild type, it can be a sort of a valuable internal control, if you will, in some respects. At least I use it that way in the endometrium or the ovary at times.
Yeah.
So.
Okay. Yeah. Thank you. That's a good point.
Well, this has been a great session. We've gone a little bit long, but I appreciate everybody's patience and Paari, your flexibility and retooling onto a different meeting site. And we will look forward to having another session and getting this posted online for people to review and study. And of course, I assume that the slide links will remain live for people to review as well.
Absolutely. Yeah.
Well, thank you very much. And I guess that ends the program.
All right. Thank you, Dr. Hassel, and thank you everyone for attending the session.
Send me a link to the recording so I can post it some way or another, either a Google link or something of that sort, so I can get it uploaded to YouTube.
Yeah, we'll certainly do that. Okay.
Thank you, everyone.
Take care. Bye.